Good morning, everyone. Thank you for coming out today, and we're going to keep it kind of casual, but informative as well too. My name is Christopher Cunny. I like to describe myself as a recovering CIO now, healthcare technology strategist, advocate, disruptor. I wear a couple different hats. I serve as the managing partner for IoTech Consulting. We are a management consulting and solutions firm. And I'm also an investor in tech startups. Today I'm representing one of those startups, Ask Me Your MD, or Amy MD, which is a urgent care virtual platform for, we cover over 25 different specialties in all of 50 states, including Guam and Puerto Rico, for $35. You can get healthcare from us. I'm going to just let each of my colleagues here introduce themselves and we'll jump into the discussion for today.
Great. Good morning. It's great to be here. Rich Mulry. I'm the CEO for Northwell Holdings. It's the corporate venture investment arm for Northwell Health. We have an objective really to introduce innovation and technology into the health system in a way that's aligned with our mission, but really brings risk-adjusted returns back to the system so we can offset the margin. And we do that in a couple of different ways. We have our history of just investing off balance sheet in early stage companies. We have about 20 active companies in that portfolio. And more recently, we've been launching our own companies where we've seen a gap in the market. We realized we had a wealth of experience and knowledge within our own walls. So we've taken it upon ourselves to ideate on what we think could be important for us as a solution, what could be important in the market. We've done that in two ways, just ourselves. We've launched a telehealth company, Commercial Air, which is selling in the Middle East and Asia right now. And we've launched 4 AI companies with Aegis Ventures, which is a company creation platform. And then lastly, we are very, very committed to internal innovation. So we have over 100,000 employees every year. We launch a campaign to have them submit their best ideas and what they think could solve problems in healthcare. And then we go through almost a month. The lawyers say I can't say Shark Tank, so I didn't say Shark Tank, but an equivalent contest where they're judged by external judges. We try to seed those and bring them to market. And there's 4 companies that we've been able to launch for those. Much longer path. It's a labor of love to do that, but we think it's also important to sustain a culture of innovation and also see where these ideas could go out into the market.
Thank you.
Good morning, Ryan Sadagian. I'm a Chief Medical Information Officer at the University of Toledo Health, also practicing pediatrician. I still practice medicine beside the administrative role. I started my career as a healthcare consultant before even I went to medical school. So been in the industry, then went off to medical school, took a completely different turn. During my training, it was right about the time with Obamacare. And I thought in the next decade or so, we need more physicians who understand data, machine learning, all the cool stuff in technology that it was not part of the medical training, and it's still to this date not part of many medical training. So I took a different route, went to NIH, did my biomedical informatics fellowship at the University of Pittsburgh, learned a lot about machine learning and predictive analytics. Then I decided that, this is not enough. I have to continue on that path of executive track, did my MBA at Auburn University in Alabama. And at that point, I decided finally this is the time to do the pediatric training. And toward the end of my training, I came across with another opportunity at the University of Washington to do clinical informatics fellowship. So I went from biomedical to clinical, and I've been a CMIO in different hospitals from West Coast to East Coast. And for the past 3 years, with the advancement of the large language model and the new generative AI, I really focused on what we learned over a decade ago with the older technology, machine learning, to the newer one. So done a lot of interesting work at the University of Toledo that we will share with you, but glad to be here with this group.
Good morning, Kristen Miller. I teach at Georgetown University. I do a lot of operational research work at MedStar Health. My primary role is the scientific director of the MedStar Health National Center for Human Factors in Healthcare. So on the human factor side, we think about workflow, integration, usability, user-centered design, and we've been supporting a ton of AI-related initiatives, anything from radiology AI to ambient digital scribe work. My research specifically is focused on the patient perspective, so we've been doing a lot of work with patients first and foremost to understand how they think about AI. When we use AI, how should we communicate it to them? Thinking about things like transparency, privacy, trust. And now we're designing, developing, deploying, evaluating patient-facing AI-related things. We have some exciting things in the works. AI agents basically serving as chatbots for patients that we can personalize and tailor to their preferences, but also things like CDS-related initiatives, using the patient portal, all kinds of exciting things that I think are really as we forecast where we're going with AI in the patient space.
Dr. Chow?
Yeah, my name is Chow. I'm also a pediatrician. I wonder if I'm at the right conference. I do know that pediatricians love toys, so maybe at the right conference. I spent 32 years at Kaiser Permanente, 8 of the last years as the National Director for Innovation, where we looked at over probably 2,300 startups in health tech. And at that time, it was wild. Maybe not as wild as COVID, but it was wild. After that, I retired early in 2014. I joined federal IT contractor as a chief innovation officer. So I worked with the VA and the DoD, and that was a very fascinating culture in Washington, D.C. And then after that, I spent 2.5 years at Amgen as a digital medicine lead. Like I was telling one of the attendees, none of these positions I was really qualified for, but that didn't stop me. So I think you got to keep learning. So that was a very fascinating, Amgen is a great company. So I did that, digital medicine, telemedicine, virtual sensors, things like that. And then 6 years ago, I was approached by Automation Anywhere to lead their healthcare vertical right before COVID. And so it was quite a challenge, but today we have a very well established healthcare vertical, and I'm glad to be here. And I've been here before, and it's always been a great conference. I'm glad to meet anybody who wants to talk. Yeah.
Well, as you can see, we have an amazing group of very knowledgeable and talented experts. Let me just kind of, and so I'm happy to jump into the conversation that we're going to have today too. So let me just kind of set the stage for everyone. This topic is Anonymous Allies, how AI agents are transforming healthcare operations, and just a little bit of an overview. Administrative overloads consistently divert healthcare professionals from patient care. We'll talk today about how healthcare organizations are implementing autonomous AI agents that independently complete complex tasks, reducing administrative burden while also improving accuracy, efficiency, and staff satisfaction across clinical and operation workflow. Definitely want to talk about whether you're seeing that as well too in our conversation. Let's jump into the first topic for our conversation, really defining AI agents in the real world. Since ChatGPT, everyone claims that they have an AI agent. Those of you who have gone to HIMSS and Vive and Health, every company that was there said they had AI built into their solutions now. And so for our audience of leaders, how do you define what a true AI agent is versus marketing hype? And should CIOs and CMIOs and other decision makers actually be looking, what should those individuals actually be looking for when we say we have AI agents built into our platform? I'm going to start with you, Dr. Chow.
Yeah, let me take a crack at that.
Yeah.
I think for me, the simplest definition, there are many definitions of an AI agent, as many as there are companies trying to sell you AI agents. But the cleanest definition is that it's a software entity that can perceive its environment, can sense, can analyze it, can make a decision, and can act for the sake of a defined goal with minimum human interaction, minimum human supervision. Different from previous automations is that an AI agent can adapt, it can learn, it can evolve. I think that's the key part. So if you're a C-level executive, you're not seeing that it's just an automation. Yeah.
It's just a rules-based engine, right? Kristen, any thoughts on that?
Yeah, it's interesting because I think working with patients and trying to put it in words that they can understand as well. And so some of the things that we've been talking about is automation, but with a little bit of intelligence. So for anything where there's decisions being made, it's not that rule-based logic, right? If this, then that, but there's a little bit more thought behind it. So one example we've been using, work in palliative care, traditionally alerts would fire and say this patient needs, palliative care, needs home hospice. But the new AI tools are more smartly thinking about that patient's trajectory. So that it's not just black and white, but putting things more into context as we deliver information to providers.
Sounds good. And gentlemen, both of you, as you answer the question, help that CIO or that CMIO or decision maker understand what questions should they be asking vendors? How do you validate that this is truly an intelligent bot that's been developed?
Mhm.
Yeah, I mean, there's for the past several months, there's really no weeks that we get knock on our doors that we want to talk to some vendors
Right.
about, hey, we have something for you. And you know, um, having that machine learning background, I always the first thing I really want to learn about what they're selling is, what algorithm are you using to basically solve what problems, right? Because you're trying to sell me something. The number one things for you to know is what workflow does my organization has. As I said, as a CMIO, everywhere I go, if I start a new job, I always tell the senior leadership, it almost feels like I'm starting from ground zero, because the first few months I really need to learn about the organization. I need to learn about your workflow, which is different from the prior organization. I can bring you experience, but I really need to understand how you build that agent, how you build
Right.
your algorithm. What are you trying to solve my problem? This is the first call we're having. You haven't even asked me anything about my clinical, non-clinical operation, but you're trying to sell me a product that I then have to see if there's a fit.
Exactly.
And the other two questions I always ask myself and ask the vendors, is that something that you're going to fill the gap for my operational, non-operational problem? Or is it some sort of innovative approach that we haven't thought about it,
Sure.
and we're using this technology to be more innovative in the service we provider for the patient care, rather than I need something to fill this gap, where a lot of advertisement you see that, hey, we're replacing your human resource with this AI agent. Well, maybe something that is more innovative for my organization, rather than just filling the gap or the things that that the advertisement is for. But those are the really high level that I always challenge and question the vendor within the first 15 minutes to really realize, do they even know what their own product is?
Is it a solution looking for a problem, right?
Exactly.
Right.
Yeah, no, I couldn't agree more. And that's part of the reason we get over 100 different requests a week for companies looking for either some affiliation or investment. Um, most of the time, we were getting a solution that was thought of by somebody who was brilliant in tech and then had absolutely no understanding of healthcare whatsoever. The only reason I ended up in venture, though, I'm a healthcare operator, and by training in public health, all of the deals that we were writing weren't getting launched.
Right.
Because nobody worked in healthcare that wrote the deals. So they just went in, and certainly, and it was an interesting journey, but we've taken an approach a couple of different ways. We never assume that we know everything. We know what we know very well. We want to partner with other systems and then the smartest companies. Part of the reason we decided to build our own companies, we built our own data lakehouse to inform the LLMs on our workflow, because we weren't seeing that out in the market as readily and people didn't really understand us. But that's not to say we're going to build everything new. The other is the recognition when you talk to a CIO, can we trust it? Again, speaks to the validation piece, I think, and others smarter than I will evaluate, where has it trained? How is it constantly monitored? Is it going to drift? How are we checking that? The other is it efficient? And does it do what it was supposed to do? And I guess we try that through a series of pilots. And then we decide if we want to have enterprise scale. And then, lastly is CIO is always, believe it or not, more and more increasingly interested in the cost, right? What
Absolutely.
the ROI, which we're applying a very, very tight lens to agents, I think, more so than any other tech that we've done in the past, where we're looking for specific ROI right out of the gate for these solutions, which it might be a little myopic, I think. I think we should try to have a bit of a wider lens, but it's new territory and early stage for all of this, or at least for us. And I think we're going to just have to go down that journey and educate everybody as we go along, because there's also not a uniform understanding of what this is and what it can do and how we're supposed to use it.
No, absolutely. And I think to your point also, ROI is not always dollars and cents, right? Can we quantify that in a way that's aligned with the strategic objective for the institution itself? As you apply these technologies to support those initiatives, I think is also extremely important as well. Let's move on to what we call baby steps versus bold moves, right? The implementation of these technologies. There's this tension that we all have experienced, I'm sure, about being cautious and taking baby steps when it comes to the adoption of these technologies. I'll start with you, Richard. Have you mentioned, talk to us a little bit about, this approach about being very aggressive around things like administrative workflows versus maybe taking a more cautious approach around the clinical side. What's the balance and what's the risk that you've seen and have had to navigate when you think about implementing these types of technologies?
Yeah, sure. And an aggressive approach doesn't always mean we're doing it quickly,
Right.
unfortunately. But what we've tried to do, I think, is be a leader, not a follower. We don't want to have from 2 years from now just look to see what worked for everybody else. We're trying to figure out what we can do. We're looking at either native AI, which is going to just re-engineer or create an entire workflow, versus applying AI, integrating it into a workflow. And we don't want to automate a bad process. So we're stopping to think about where can we just remove entire sections of work that the agents can work on and do it very efficiently. So, I mean, we started more heavily on the administrative side, not on the clinical side. When we're looking at clinical, we're working for more industry partnership than we are developing our own solutions, just for the time and effort. And we think we have an opportunity to partner and help validate that. But where we've seen just an early stage example, it's of course it's in the pre-auth space, but working with our transitions of care team and the team coming in and within 3 weeks, understanding their entire workflow, breaking it down, looking at every click they made and every process and every call that they had to make and every email they had to send. It brought it down from 150 clicks to 6 clicks. It brought the consolidation of the case that needed to be reviewed down from 2 hours to about literally 6 seconds. And so we're really excited that now the case managers can look at this and spend time with the patient's families, looking at the most appropriate placement. The chase functions no longer require us to go say, could you please put your ambulation plan in here so we could do it? And then the agents themselves can call the payers. And there's been a lot of interesting, I know eventually we'll be talking to their agents and we'll have to figure all of that out at some point. But more interesting, we invested in a company called Hume, which is empathic AI, and it can create voices based on its interpretation of your mood. We found our first agents because it was a rules-based engine, wanted to get the auth. So all it did was want to get the auth. It was offending everybody at the payers and getting them very upset because they didn't really want to talk to our bots. Quite frankly, there's a lot of friction. We developer toolkit put Hume in there so the bot could sense when the other person was getting a little more agitated. It made them ask for the auth a little more nicely. And we actually were more successful in getting the auths. So lots and lots of still early steps, but lots of learning still to be made.
That sounds good. I'll pose that same question to the other panelists. Any comments, thoughts?
So for our organization, I started that discussion last summer around the same time. And I said, there's this new large language model, generative AI, you guys hear all over. And there are a lot of capabilities, right? Let's not look at what is out there. Let's look at what we need, right? And so I want to look at our College of Medicine, which is tightly, tied to our hospital, and we're a small organization, so a lot of people wear a lot of hats, right? So our physicians who are associate program directors, but also associate dean to the College of Medicine, they also see patients. So when I was talking to the dean and senior leadership, I said, can we think of something that is going to really help the organization, right? we can also, our partner Epic, we spent a lot of money on our EMR and see what they have on the pipeline. That's something separate, but we are a bigger organization than just Epic. EMR is not everything, right? So surprisingly, we found some of the stuff we found was very interesting. The faculty said, I don't know these AI things, but it would be very helpful. We have 175 students per year, and I take care of 40 students. I have to correct their SOAP notes every week. Right. Can you build us something that I can give the SOAP notes with our rubrics and give me the feedback? Because I'm always behind, right? And the other faculty said, we're getting thousands of applicants. Is there something we can build that help our committee to go over and filter those candidates and get them for interview? And once we pass the interview, for the second round, review our notes to see who we want to send the offer letter. So the things that really help the organization that never done it. We haven't even looked into any vendors that they were doing it. And if any, you don't want to really add more costs, especially at this time with our, everything going on in the country. So we don't want to add more costs. So we start looking different part of the organization. What can we do with this type of technology to actually bring some innovation to help us with the workflow?
Kristen or Dr. Chow, any comments?
Yeah, yeah. In my travels, talking with numerous health systems are trying to grapple with what is AI and what is automation, where do we use it, correctly. I think one of the challenges is there's a lack of information, lack of education. Right. So operating out of ignorance, and not to mention the noise in the market, it's really challenging to figure out what to do. And so what we've taken as an approach is to talk with the C-suite and say, this is a strategy for you, for AI strategy. It's vendor agnostic, right? AI strategy, what should you do first? Second, third, where do you get the early return so that you can justify? And we've brought in a very strict, like you guys, business value framework. That we can plug in your own numbers and actually get the promised return and see you get those returns. I think it's hard because AI leads us into a new era. I really think it is. It's like internet. So when we think about the place of AI, should we take baby steps? The bigger question is, what is the role of AI? And I think I get the feeling it's part of the transformation stack. It's not a point solution. This is a bigger tool. And so we're still working with that. It's still early. Lots of people, grappling with it. So
It's definitely a journey, not a destination. Again, one of the biggest challenges we have, and it leads follow up to this conversation in terms of that acceleration of adoption, is around governance and trust, right? At the end of the day, I mean, organizations aren't comfortable with it. They're not familiar with it. They don't trust it, or they're concerned about the efficacy of it. And that speed of adoption has a lot of impact. I want to get your thoughts on that, and I'll start with Kristen as well too. This progress moves at the speed of trust, right? With the legal and governance and ethics concerning AI agents. How are you building that kind of organized confidence? What type of structures are you putting in place to ensure that individuals, decision makers, patients, are comfortable with the efficacy of the technologies now that are being deployed, that are now being relied upon to make decisions independent of human intervention?
I like that line, progress moves at this. So I think maybe I'll start at the federal level, because I think there are folks that feel very strongly about this, and they sort of fall into two camps. One is the more assurance lab network, right? That's the Coalition for Health AI, the FDA, the ONC, who think that if we look at this at a federal level, and even if we make sort of pockets of data from healthcare systems across the country, that we can test and validate at that higher level. And then I think the second camp is more local, right? This needs to be micro level. We need to test at a local level. That's like the Health AI partnership groups. I think that we feel like there's shared responsibility and it probably falls within both. And when I think about the evaluation and how we look at trust and sort of the socio-technical piece of this with a human factors lens, it's not unlike any other healthcare delivery initiative where we're looking at the evaluation to say, does it work? Yes or no. That's important, right? That's the quantification, that's the ROI. I actually care more about how does it work and in what context does it work. So for example, we've been doing a ton with the ambient digital scribes and trying to understand, is it patient level characteristics? Does this work for certain patients over others, right? Does it not work for patients that don't speak English? Does it work really well for patients with complex diagnoses? Or is it actually provider level characteristics? Does it work really well for new physicians and, more experienced ones don't need it? Is it system level consideration? So we're trying to take this, systems thinking lens to see what the real needs are and then how we can evaluate it to demonstrate whether it was successful. And I think that thoughtfulness is what really builds sort of the trust and then introducing future things with people feeling fully confident that we've thought about their needs.
I guess from a provider perspective, what types of governance models are you putting in place to ensure that efficacy and confidence in the use of these technologies? But you want
In our organization, one of the very first conversation we had around that with the president of the university who oversees the hospital and the university was, we need to create this organizational wide education on this technology. And that includes the deans, chief privacy officer, chief legal officers, and then the hospital administrators. Because every time we go with this contract, and I was just reviewing a contract last week, and our legal had a hard time understanding some of the terms, right? Because to this day, they were like, okay, Ryan, explain it to me. Are we keeping the data here or is it on the cloud? I said, none of them. This is a different type of, information we're talking. When you use this generative AI on this platform, your information get processed through their engine, come back to us. It was like, so where is that? I said, it's nowhere, but you're sharing that. So for them, it was difficult to understand, and it's not their fault, right? It is not something the legal team are used to. So partnering with those, I think it was very critical, because then everything would stall, right? If your privacy and your legal don't understand what you're going to sign, you're never going to get that, right? Then we went on the micro level, and then we said, okay, we need to educate our medical executive committee, right? So every month that we had our meeting, we brought a various small pieces of information into the MEC, how the chairs understand what this technology we're going to bring, again, innovation versus what Epic is going to put. Right. And then the last part, we created what we call trusted advisors within every medical specialty. So the chair would assign a trusted physician who is interested in technology, and then we work directly with them to communicate that, because the chairs are doing an operational part, right? Who are in the weeds are program directors, those physicians. We have a training program, so residents and fellows. So where can we fit the balance where the chairs make the operational decision, but the people in the middle are doing the work in the division? So we created extensive trusted advisors across the entire system, not only for physician, for nurses, for inpatient, outpatient operations. So now we know who we need to plug in when we want to have this discussion. And the organization, as part of change management, they start understanding that it is the responsibility of those trusted advisors to communicate this conversation to their respective division.
Yeah, I couldn't agree more. When we look at it at a macro level, when we were setting up who should be on these groups, it's clunky in the beginning.
Right.
I think we agreed in principle, if we could get better and smarter at looking at figuring out what we needed to look at, a good governance structure was actually going to reduce the bureaucracy and not increase it, because all you have to use the word committee inside a health system, and you know that's absolutely the best way to kill something, right? So, yes, you're going to committee. Why don't you like me? But then downstream, I agree. I think there's key responsibilities across the organization and leadership positions, and the way that we've even just had to do it on our own too is every single person is responsible in some way, shape, or form if they're using something that has an AI application. So that human in the loop has the right and the responsibility, almost like a timeout in an operating room, to question what they see. And if they agree with it, whether or not we get desensitized over time to that and just constantly accept what comes in, it's super important now to make sure it is, because we're not exactly sure that how we're training everything is exactly how we should. So it's early days, but I think it's a combination of exactly what you said.
Absolutely. And then Dr. Chow, from the vendor's perspective, what are you doing to support your clients and ensuring that governance?
Yeah, so we actually do consultations and professional services. So we actually talk with clients about their plans and their priorities and try to make it make sense, where you adapt to AI, where you don't. One of the issues is that we're seeing is that there's a lot of experimentation with AI across organizations. And what that does is it creates this technical debt, this AI debt. And that's part of the cost. When you look at benefits, costs, and risks, that's part of the cost. And so it's early. A lot of people are experimenting. And at some point, you're going to have to make 50, 100 LLMs talk to each other and figure out which one is going to be the top LLM. And some of these are proprietary. So it's a very interesting time. I think we have a framework that we can talk with people. I'd love to talk with people about that. But again, it's an early time, and just realizing the risk, but the real benefits. Uh, it's exciting.
I wanted to do a time check real quick. I wasn't sure how much more time we had.
Keep going into your tackle.
Okay, good. All right, well, we'll keep going then, since no one has put the hook out for us yet. Um, vendor reality check and technology stack. Let's talk a little bit about that. So there's a unreliability in the vendor's promises, right? In the real, promises and limited real content. Where do AI agents actually fit in the technology stack? And how do you assess the real value when vendors barely know what they're offering? And then what questions should leaders be asking vendors? I mean, that's a toss-up, so I'll let anyone jump on that one.
I won't speak about the stack because it's not my space, but I can talk about the hype.
Yes, that's
Only because we are creating our own solutions and we're being bombarded with outside solutions. And we've literally been presented across the organization. This company can do an 80% savings on this and they have 90% efficiency. I'm like, they absolutely don't. There's zero chance that that's true. And I don't, other than just a PowerPoint or a tear sheet, there's no way that that's true. And
Exactly.
they can't
They don't have
validate
case
it.
studies either to show it.
Absolutely. So all you have to ask is show me the data, and there are no data
Exactly.
relative to that. So I think we just have to be realistic about what we're trying to achieve, what makes sense, and then just start along a path where we're trying to measure the best way that we know how.
Absolutely.
How it's embedded in the system and how there are people smarter than I in the organization that help us get there. But we realize that we have to have a critical eye and a skeptical eye towards what we're hearing until we can, help validate it ourselves.
I would say because if the vendor comes in, we had a conversation last week with the vendor that was supposedly, we came through our chief financial officer, want to help us with our revenues. And so they put a slide on the screen and they were keep going. I was like, can you please stop? That this slide really, drew my attention. So let's just talk about this. Let's, they had about 35. We stay on slide number 5. And I said, I really want you guys to explain to me the diagram that you put in, because you're showing that you're getting our information from coding. You run it to this strange name, machine learning AI agent you have, and then you spit out all of this. Let's talk about this, because I want to learn about this. And that conversation took 45 minutes. They had to set up another call with the technical team to come. That took for another hour. They still didn't get the answer that I want. So we went to the third call, and our COO, who retired but is still on board to work as a consultant on a couple of projects we had. So she works with me closely. And I said, I want to get to the bottom of this because this is how you ask them the questions, right? These people are selling us, but, and the statistic to your point that they put on the screen, I questioned that as well. I said, the generative AI and the large language model has been around for a very short time, right? So when you say about 95% improvement efficiency and reduced denial, is it based on the information from the last 2 years or is it based on since the company established?
Exactly.
Right? And I need that difference because I want to know what your engine, slide number 5, remember that, does that you claim that 95%. And I would like for you to connect me with some of the clients, all this, Stanford, all this, picture you put on the slide number 5 again, to connect me with some of those clients, because if you guys have been doing this for the past 2 years, I got to say, you guys are genius, right?
Exactly.
But being, having done those large language model, and we built over 1,200 applications and logics over the past 5 years, it just blows my mind that you're able to do it. Again, if you do it, you get my golden stamp here.
Right.
But I'm just curious because the senior leadership rely on my decision now, whether or not you're going to reduce our denial, right? And improve our revenue. And final questions. Have you looked at what our vendors Epic is offering, because they have a barrage of generative AI features that we're signing up for?
Sure.
And where do you stand with them? Again, after third call, no
You gotta
answers.
kiss the ring. You gotta
So,
kiss that
so
ring.
I think it's really important to be able to ask those questions because again, there are a lot of hypes. There's not much a statistic out there. Again,
Right.
this is fairly new. If they said we have done it with 2 organizations and they were very happy, I'll take that. But 95% and UCI, Stanford, well, CMIO, CIO, we're a smaller, community. We know each other. So you can reach out and say, hey, were you part of this study, through generative AI, or you used them 15 years ago?
Right.
So
Makes sense. I did get the 2-minute warning earlier. So I do want to open it up to the audience, but I want to see if either one of you had any comments on this last question before we did that.
I mean, I have more questions than answers, I think,
Okay.
because the technology is moving so quickly. Like 2 months ago, I couldn't make a picture on ChatGPT, and now I can make like graphic novels, right? So as we're introducing things, it's hard to know like the quality of. I mean, our research team has intentionally stayed away from any sort of evaluation of is this tool good or not,
Right.
because tomorrow it's going to be a different tool. So how do you explain that to your stakeholders to say, like, I don't know how great it is, and it's probably going to get better.
That's right.
It's a moving target.
Good comment.
Yeah, I think when you look at vendors, you need to really look at documented objective differentiation. And, like you were mentioning, actual case studies that you can talk to the people and say, what did you achieve? But also things like, for instance, our platform is the only platform that's certified end-to-end by HITRUST. That's table stakes for healthcare. We're the only platform that has a healthcare team, which tells you a lot, about platforms. But the idea of a platform is that we play above other systems. And Epic has great AI, and there'll be a lot of other things coming out. We've seen AI from Salesforce, Workday, and whatever. But they don't play outside their ecosystem, and that's one of the issues. Again, like I mentioned before, we're getting to silos. So.
Do we have time for a question or two? Assuming we do until somebody tells me to stop. Do we? Okay, one question. I knew you've been raising your hand for a minute. Yeah.
Okay, I'm going for a big one on the table. You may all deny wanting to give an answer, which may give time for another question. But from a long-term strategic standpoint, right, is this going to be able to be technology that we can take 1 or 2% of margins out of, potentially to reinvest in other really needed areas? Like, what do you think is there sort of strategically and structurally? Like, understand it's not there today, but healthcare does need to find ways to save money eventually. And this seems like the best hope on the table outside of value-based care, which is like structurally even harder and longer. And let me just throw that big one out on you.
I would say yes, but it really depends on how you approach and what problems are you trying to solve. The very first thing I did, because in our organization, I reached out to our chair of engineering department at the university, and I said, if you want to do that at the hospital and campus level, do you have faculty resources or student or graduate levels or PhD that then they can help us with build, because we're thinking about building internally rather than spending a lot of money on the vendors. Then you can also control, and to her point, with the advancement and changes in the large language model, you have a better control of that. So I think to your answer, it would be very specific to how you're approaching this technology and what problems are you trying to address.
And I would-
Thoughts?
Yeah, I would say that it depends on what you're looking at. Healthcare is full of structure, very rigid structures, a lot of interdependencies, a lot of people that are afraid that AI will take their jobs. And so when you redesign your organization, or if you try to redesign your organization, first of all, you talk to unions, you talk to them, so that's that. I was at Kaiser. And you talk to those folks and you have to educate them, understand this is how you're going to be more productive. For the coming demand in healthcare, the aging population that we can't even meet today. And so you have to present an argument not on economics, but ultimately ends up beneficial economically for everybody. And I think that's a long-term challenge. It's a big change.
Well, for those of you who didn't get your questions answered, I'm sure our panelists will be around most of the day, so we'll stop them and have a conversation with them. Thank you for allowing me to moderate this panel. Thanks for the great insights we got today.